of essentially blocks in terms of the site that aimed to bring like-minded services together in the right area. So what we were trying to do was make sense of a site that's been that has evolved and adapted over a very long time, where we've now got services in the wrong place with the wrong adjacencies. So we wanted to try and set out a phased program of work that started to unpick that with a mixture of both old refurbishment of the old estate and building of new estate. Next slide. What the site development plan then did was it mapped out essentially a program of work over a decade or more that started to put in place all the building blocks that we needed to underpin the changes to the clinical models. And the figure over the left really gives you a bit of a sort of snapshot in terms of the number of schemes that we had across the whole of the building that aimed to unpick this. Next slide. What I'll do now is just walk through some of the schemes that are underway currently or have been delivered recently, just to try and set them in context. Next slide. Last week we had the announcement in the Houses of Parliament around the continuing commitment to the Phase 1 scheme, the new urgent and emergency care facility. So that facility we've been designing now for nearly 5 years. And is a really important gateway development for Derriford. What that will see is a 4-storey building built adjacent to the main entrance that will absolutely transform the way in which we deliver urgent emergency care and more. Next slide. The next slide sort of really does set in context why this is needed. So on the screen, you've got some data in terms of the position in terms of ED, both in terms of the average number of people within the department and the peak position in terms of people in the department. So if you look from about February, March, April 2021, we tipped over in terms of having more patients in the department than we've got capacity. And when you look at the chart on the right, you see the extent of time over the course of the day when the department is crowded. So we're now operating with in excess of 20 hours a day with more patients in the department than we can comfortably cope with. So the new building will double the amount of space that we've got in terms of urgent emergency care. Next slide. So just to walk through the building, so the ground floor, the level 6 floor adjacent to the main entrance will be the provision of essentially our triage and our resus and majors. So the area that will re-provide most of what's now delivered across the area in pink that's just behind. So as you can see, it's sort of double the space. Embedded within that area, there'll be all of the imaging that's needed to support essentially our front door services. When we've moved the adult emergency department into the new building, the area in pink will be converted into a dedicated paediatric emergency department. And we've chosen that location so that we've got the ability to then build further back into the hospital and co-locate all of the services that are needed for paediatrics. So starting with paediatric assessment, paediatric inpatient wards and paediatric theatres. Next slide. The next floor is all around same-day emergency care, and clearly, unless we put a real focus and have a real transformation in terms of bringing together all of our same-day emergency care pathways at the front door, we'll end up in a position where we create a much bigger facility, but that bigger facility is then just used as a sort of holding area for admission to Derriford. So getting the pathways right in terms of same-day emergency care is absolutely critical. What we've done in terms of this floor is also included a 24-bedded short stay ward. So again, we've got the ability to keep people overnight where we need, for example, to put packages of care in or where they need physio referrals in the morning. So again, trying to put in place all of the services in the right place. Also on that floor, we've got imaging capacity again to reflect all of the services that we need to operate an effective same-day emergency care service. Next slide. The next floor is a floor that's dedicated to our interventional radiology suites. We've currently got two, just built a third IR suite, and those theatres are used to support both inpatient and emergency services. So things like our stroke thrombectomy service is delivered through that facility, and some of our neurological services. We will see an increase in expansion of capacity here, moving to essentially 5 IR suites, and those will come on stream, and I'll talk in a moment about how we're going to bridge the time between now and when these open. There'll be a dedicated recovery unit, so again we can do same day activity from this level. Next slide. The top clinical floor is conventional theatres, and in order to try and provide enough theatre capacity to make sense, we've dedicated this floor to both urgent and scheduled activity. So this will provide 5 new operating theatres. As we work through we'll come to questions at the end, Juliet, if that's okay. So as we work through the same day emergency care pathways, what we're looking to do is gain essentially bed days back as a result of reducing the crowding that we've got in the current emergency department, and then essentially these theatres will use those additional bed days for additional activity. Next slide. There's a lot of work going on at the moment at the top end of the site that's really the preparation work for the build. So we're aiming for the new building works to start probably February or March next year. And ahead of that, we've got a lot of works to do to divert services that are in the area that will be the construction zone, and ultimately to raise the area in pink on here to the ground. That's what used to be Plym day case. So what you'll see happening at the top end of the site over the coming weeks and months is quite a lot of works in the ED courtyard and the area surrounding what will be the building site. And then we're aiming for demolition to take place August, September time to create a clean site really for the developer to start work. Next slide. Another of the really critical enabling steps is to relocate the paediatric emergency department from the extension that's in the emergency department courtyard into an area that they can stay for the life of the build, and that area is currently occupied by Fracture Clinic. So one of the critical steps is to move Fracture Clinic out of that area, and we've got funding secured, and there's a planning application in at the moment for a building that will see the Fracture Clinic relocated to the area that's on the Derriford site, very close to the Rowans building. That will be a single-storey building, but we've also got plans and a bid in at the moment for creating an urgent treatment centre that will essentially sit next door. And this is part of a much bigger building that we would envisage taking place on that site that would bring a range of services that don't need to be delivered from the Derriford Hospital footprint into an area that's located on the site. In terms of Fracture Clinic, we're aiming to get that open by September time to coincide with the demolition of Plym. Next slide. Clearly, the issue of crowding extends way beyond having the right capacity at the front door and the right same-day emergency care services. There's been a lot of work over the past year or so in terms of thinking about the services that we need to wrap around the hospital to ensure that we can discharge patients effectively, both in terms of nursing home capacity, but also some of the step-down care. So on the slide here, you've got three photographs. The Patricia and William Venton Centre, which was a facility just at the edge of the Mount Gould site, aimed at essentially step-down care. More recently, we've opened Saltram and Lopez wards part of wards 5 to 8 on the Mount Gould site as a further discharge assessment unit, again taking sort of pathway 1, pathway 2 discharge to assess patients. There's 40 beds there which are already having an impact in terms of de-escalating the hospital. The last graphic on this slide is Colebrook Manor. So just before the end of the close of last financial year, we were awarded some funding in collaboration with Level to buy Colebrook Manor in Plympton. We're currently working up a plan and a business case for how we will use that again as part of our discharge pathways. So watch this space in terms of how we can turn that facility into, again, more capacity to start de-escalating the hospital. Next slide. Okay, so that was a sort of whistle-stop tour through some of the urgent and emergency care activities. I'll just talk very briefly about a couple of schemes that are currently ongoing to increase elective capacity. So next slide. For the last 12 months, we've been working on a building that's located just close to the range, very close to the Derriford site, that will form the new home for the Royal Eye Infirmary. This will be a Devon system asset in terms of ophthalmology services, and we'll see additional theatre and outpatient capacity. So we'll go from 2 theatres to 3, with a significant step up in terms of outpatient capacity as well. What that will do is clearly it has an impact in terms of our ophthalmology services, but it also releases space in the main hospital building that can be repurposed. And I'll talk about how we're going to use that space in a bit. Next slide. That's a photograph of that was taken reasonably recently. So we're coming to the end of that build, and we should see that open in July now. Next slide. Orthopaedic theatres. Last year we were awarded some funding to create 3 new orthopaedic theatres on the Derriford site as part of the broader Devon system elective recovery. That work is now well underway. It's a complex scheme because it involves taking a number of services out from the hospital and building the theatres adjacent to some existing theatres down on level 2. So to give you an idea of the kind of enabling works that we've had to complete, the hospital kitchens that serve essentially all of our inpatient catering service have needed to be moved from level 2 of the hospital to a building on a business park not very far from here, Bridge House. So we've converted what was an office accommodation into kitchens, and those kitchens have now moved. So clearly, alongside that goes all of the work in terms of sustaining the hospital catering service and the logistics of getting food to and fro the hospital. We've also got moves underway for the linen services and a number of the support services, and that frees the footprint on that level to be converted into theatres. We've had to pick that location because it's the only location that we've got on the Derriford site where you can physically build theatres adjacent to existing theatres, so that you've got enough capacity to sustain them in the long term. So work's started on the theatre build themselves, and we're aiming to get those open by the 20th of November. Next slide. In terms of other services, next slide. The interventional theatre suites in the new building, the new phase 1 building, will open in sort of late 2025. All of our current equipment is at the end of its life, and we're operating in rooms that are way too small to be effective for the services that we're now trying to offer. So very recently we upgraded one of our interventional radiology rooms, and that's a photograph on the slide. And to give you a sort of sense, that room is about half the size of the rooms that will be in the new facility, and is twice the size of the rooms that we're currently operating in. So we're just going through and refurbishing a second, and then we'll replace the equipment in the third, and then that equipment will move into the new building in 2025. So those are important enabling steps to get us to the phase 1 building opening in 25, 26. Next slide. We've also got work going on across the site to upgrade our cardiac cath lab capacity. So our 2 cardiac cath labs are 22, 23 years old now and are at the end of their life. In order to sustain capacity, we've got a scheme that's building essentially a new cath lab to replace a pacing theatre, and that's going in a light well, and that will also lead to a brand new cardiology department. Anybody that's gone through our cardiology department, ECG suite, will know the accommodation is really poor quality. So we've essentially taken down that single story extension and built in the light well to form a new cardiology department and a decant cath lab. We'll also put a second decant cath lab temporarily on the site, so that we can take the 2 existing cath labs down and replace the equipment. And that work will happen towards the tail end of this financial year. Next slide. At the back end of the site, near where the theatres are going, actually, there's a building project going on to build a new radiotherapy decant bunker. We've got 3 linacs, all of which are fully utilised, and all of which are now reaching or have reached their 10-year life. So in order to replace those linacs, we're building a decant bunker, and that bunker will then become permanent and will house one of the replacement linacs. We've taken the opportunity to design a facility here that allows us to extend the range of services that we offer and put the services in a much more fit for purpose environment. So things like brachytherapy, which we're undertaking under general anaesthetic, we've now got a purpose-built facility that will enable us to do that. So that work's started, and we're about 14 months away from concluding the first part of the works, and then we'll roll straight into replacement of the existing linacs in the other bunkers. Next slide. In terms of bed capacity, I promised to talk about the impact of moving the REI off-site. So if you go to the next slide, this is a busy slide, but in the top left, you've got the area in sort of the dotted line that was the footprint of REI, or is the footprint of the Royal Eye Infirmary currently. Historically, that was 2 wards, Kerry and Avon. Avon was our hemodialysis unit, and Kerry was a ward. And what we're intending to do is convert the area that's closest to the Royal Eye Infirmary entrance into a new chemo day case unit, and that sits in the right area of the site to be located next to the Macmillan Mustard Tree Centre, and also close to the rest of the oncology and cancer services. So it's in the right location in the site. That service will essentially move down a floor. It's currently located on Fowl Ward, which is part of our theatre floor. And Fowl will become essentially a new neurosurgery unit, expanding our neurosurgery capacity. It's an area where we're under significant challenge in terms of waiting list position. That sits next to our neurosurgery level 1 capacity that we opened up on ward last year. The last piece of the jigsaw on that floor is then taking Moorgate Ward and converting it into additional ICU capacity. Again, like a number of organisations, we're short in terms of intensive care capacity for our population, and Moorgate is probably the only place that we can sensibly add to that capacity, located next door and able to be linked to our current general ICU and neuro ICU. But then when we've completed that work, which will be the start of next financial year, that will make sense of that floor, and everything will be in the right place finally. In terms of the other ward on level 3, Kerry Ward, we're intending to move our hepatology service down from Shipley Ward, so that essentially we've created a floor that has renal transplant, liver transplant, and the rest of our hepatology services in one place. So essentially we've got a super green floor, so that makes absolute sense. That allows us then to turn Shipley Ward, which is in amongst orthopaedics, into a trauma ward. So again, we're starting to be able to zone the site correctly in terms of having the right specialities together to make sense. Next slide. Near the maternity entrance, for anybody that's been up to the site recently, you'll see a 2-storey building that's appeared on the old maternity car park. And that building should be open now, first phase in July and then complete in August. The ground floor will be a new 24-bedded orthopaedic ward, which will go alongside the theatres and will provide the capacity we need to handle probably our most challenged service in terms of elective orthopaedics. The patients we've now got on our orthopaedic waiting list tend to be those with comorbidities, so patients that we can't put through other facilities. So this is a long-awaited development for us. The top floor will be used to solve another very significant challenge. Our urology day case unit is currently on Chestnut and is way too small for the amount of activity that we're putting through. And over time, we've increased the extent of the services we're trying to deliver through that unit. So we're doing a lot of work now in that unit that would historically have been done in theatres. So the top floor gives us an opportunity to significantly expand our urology day case unit, and that releases space in the hospital that ultimately will become an expansion to our endoscopy suite, which again is another of our challenges. So again, we're starting to make sense. In the very long term, these services will probably move elsewhere, and the building is ideally located to provide expansion capacity for women's and children's services. So if you think about this as a staging post to where we might want to be in sort of 10 years' time, it provides a building that we can then make sense of in terms of the wider site. But in the sort of short to medium term, absolutely sorts out two absolutely critical issues for us. Next slide. Next slide. So beyond the hospital site, there's a number of things going on. So we have a site at Estover that's been used for the Lighthouse testing, COVID testing laboratory for the past few years. That was always taken with the view that it would become a clinical support services site. So the legacy of that Lighthouse lab will be that we move our laboratories from the hospital site up to Estover. That releases a fair amount of fairly critical estate that we can then repurpose to form our long-term ambition of a children's hospital and sort some other issues out in that part of the site. One of the other critical infrastructure risks that we've got is around our pharmacy aseptic suite, which is now 20 plus years old, and the infrastructure is at the end of its life. So we have a scheme that we're currently getting closer to full business case that will see a new aseptic suite built in the grounds of that facility up at Estover. So again, it's part of trying to use that site as an integrated clinical support services site. Next slide. Couple of years ago now, we purchased the land that's adjacent to the hospital, the northwest quadrant. It's the area that you see on the sort of bottom right. It's mainly used for surface car parking at the moment. And we've started the process of master planning for how we use that site in the long term. So clearly one element of that will be to re-provide the parking through a multi-storey car park. But there are two really significant things we need to do on that site. The first is the Urgent Treatment Centre and Fracture Clinic, which is the wing-shaped building that's just below the sort of orange block that's currently Rowan's, and that work's now underway. The second is the building that's below it in the far left-hand side, which is essentially a planned care centre. So that allows us to then pull more of the activity out of Derriford Hospital, the activity that really doesn't need to be in an acute hospital setting, providing us with the opportunity to then expand our capacity in the longer term to match demand. So we've created an initial sort of placemaking vision for that site that sets out how we would see that site developed in the long term and the adjacencies both to the hospital but also the wider community. So that document was published a little while ago. I think that's it in terms of the slides, but just to sort of say a couple of other things in terms of some other things that are happening. So we've also recently undertaken some work to upgrade our paediatric theatres. So as part of the works through COVID to create an emergency care pathway for COVID patients, we moved our paediatric services into the Freedom Day Case unit at the rear end of the site. in order to keep that service there in the sort of medium term, we've done quite a lot of work to expand that facility and separate paediatric and adult activity. So that's a bit of a staging post to the long-term ambition of creating a dedicated paediatric facility. In doing that, we've also, working with Bristol, started repatriating some services where we've got some very significant waiting lists. So things like cleft palate surgery are now being repatriated into that facility. So an important step there. More broadly, we've got a number of projects, and I've focused very much today on the Derriford site, but there's quite a lot of stuff going on in the sort of wider community. So we've got a current bid in for one of the community diagnostics centres, and that would see a CDC built in a city centre location. That bid is in. We're hoping to hear early June in terms of whether or not that's been successful. And then more broadly, we've been undertaking some work over the past 18 months or so to start thinking about what the totality of our system estate needs are across Plymouth. So thinking about what our primary care needs are, what our community care needs are, and what the opportunities are to really make sense of the infrastructure that we have in different locations within the city and the services that we need for local populations. So that's known as the sort of Plymouth Blueprint work, and we've currently completed work in the city centre, Plympton, Plymstock. We're just concluding work in the Mount Gould area, and that's an important area because of the local care centre and the community site at Mount Gould. But we'll then move on to other areas across the city. So I think the next area we'll target is Woolwell, particularly given the housing expansion that's planned. So that's a bit of a whistle-stop tour through quite a lot of stuff, and I've tried to sort of just set some of the things that are happening in the sort of more immediate term in context, really to focus on those things that we need to get in place quite quickly to really address some of the capacity challenges that we've got. So I'm happy to take questions in a second if you want to take the slides down, Brian.
Thank you, Stuart. We've also got a few questions that we just wanted to pop up on the screen, so I will just share those with you now. So they should pop up on your screen, just if you could take a few minutes to just read through them. If they do disappear before you have time to vote, they will still then remain in the chat. So we'll just go through these ones. Thank you for that. It looks like most people have had a chance to vote. As I said, they will remain in the chat if you want to have a read through those questions, and you should be able to see the results that have come in as well. So thank you very much for that feedback. But yeah, if you just wanted to pop your hand up if you had any further questions for Stuart.
Or if there's anything I've not talked about. I know it's a very whistle-stop tour. Annette.
Hi there, Stuart. Thank you. It's been really interesting, and you've got so much on. It's like, goodness me, there's just loads on. I suppose the bit for me that you haven't mentioned, and it's so I speak as a daughter who's taken her mum to chemotherapy quite regularly at the moment. And the old adage, parking. So she's not able to use public transport. We've got to get her as close to the door as possible, because actually she's actually quite poorly, and it's hard work to get her to where she needs to be. And I suppose you've not really mentioned parking, and then you showed the quadrant, the new bit, and all that parking disappearing. And I suppose I'm sure there are plans about, but that's the bit that everybody talks about when I speak to other people. So I'm just interested to understand that, please.
Yeah, so we've actually got quite a lot of work going on the parking front, as you might imagine. So we produced a green travel plan, crikey, 5 or 6 years ago now, and that's long overdue for updating. So we've been having a series of big conversations with staff over the past 3 or 4 months to understand actually how we deal with the staff parking component, because clearly we've got to get the right balance between staff parking and public parking. And one of our challenges is that because of the shared car parks, our car parks are often full with staff. Yeah, and therefore there's not enough visitor parking. So getting that right is really important. In terms of building on car parks, I think we're now done with building on any of the further car parks around the hospital site. I guess we've been seen a number of things happen. So obviously we've seen the loss of the maternity car park. We've seen the loss of the car park adjacent to the emergency department, following the tragic accident that we had in that car park some time ago. So getting the overall sustainable transport plan for the site set is really important, and we're aiming to bring something back to board July, August time. Clearly, in terms of increasing capacity, the only real opportunity that we've got is around the northwest quadrant and the land that we bought back. So we are actively working on plans for a multi-storey car park and exploring how we might fund that in a way that doesn't rely on health capital funding. So it's sort of too early to say how we're going to do that yet, but it's an absolutely critical part of the plan. And before we lose any more car parking on that site, we absolutely need that replacement parking in place. So quite a lot of work going on, but we've got to get that balance between public and staff parking right. Nick.
Thanks, Stuart. As always, a really clear presentation. So I'm just thinking about the length of the plan that you're talking about, and you talked about it being for the next 10 years and beyond. And how do we protect ourselves from the risk of building something today that's right for today, and by the time it's complete, it's wrong? I'm thinking just as random examples, like the massive increase in amount of robotic surgery, the exponential increase in the use of AI that will happen over the next 10 years. But there are probably other things that we haven't even thought of yet. So what have we done to protect ourselves, kind of future-proof the whole planning process?
Yeah, so I guess we are wherever possible using repeatable rooms, so rooms that not only are the same for the same function, but also allow us to retrofit areas to accommodate change. I guess the other thing that we did was when the original announcement was made, we thought about creating one big plan for a new hospital, but that would involve us essentially locking in absolutely all services into one design. By setting out a sort of programmatic approach, it allows us to take this in sort of chunks. and therefore are thinking to evolve as time goes on. And clearly there's a lot happening across the Devon system and the wider peninsula that will impact in terms of the services that are delivered or not from the Derriford site. And we need to make sure that we've got the flexibility to get the demand and capacity to match as we go through this journey. So I think adopting the programmatic approach does help. I guess clearly in terms of theatres, we're trying to preempt some of the things that we've seen before. So we've got theatres, for example, where the floor loadings won't take new equipment. So we want to try and avoid that. But clearly, we can't gear up every space in the building to have all services, but we can ensure that we've got the right service ducts to be able to allow us to retrofit wherever possible. So we're preempting some of that.
Yeah. Okay, it's really clear. Thanks, Stuart.
Chris.
Thanks, Stuart. It's more of a comment for the benefit of your colleagues, really, more than a question. Just to say that as Programme Director of Torbay, I feel very cited and very supported by what's going on at UHP. And I think you've mentioned the word system on a couple of occasions throughout the presentation, and it very much is a system solution. You're very lucky to be going first, because we're going to have to wait a few more years. But from our perspective, we feel very assured that we are looking to develop a system solution for the Devon system, and we feel very much part of these discussions. So it was a thank you from us, really.
Thanks, Chris. And good luck with the future.
Indeed.
Any other questions or things I haven't touched on?
Hi, Stuart. This is Brian. I'm just going to echo the question from Michelle Thomas from Liverpool, who just had to leave. But she asked the question how you will work with community services to ensure the right estate for them.
It's a very good question, and it sort of comes back to the sort of comment I made right at the end in terms of the work we're doing to establish the Plymouth Blueprint. So that work is very much around trying to understand across sort of sub-geographies for Plymouth what the needs of our local population are based on actually the local population demographic, what infrastructure we've got currently in place, so buildings, facilities, and what services we have, and then using that to think about what the ideal would be in the future in terms of the mix of services and the kind of facilities that you might want to create. So it does it at a very high level, but it gives you a bit of a sort of template that says, actually, if there is funding available, here are the kind of things that we would want to plug in terms of that locality. And that truly has been a multi-organisation effort, and those sort of that blueprint work, although we commissioned it, I see as blueprints that are owned by the local system, and it's really important that we keep those updated as things change, and we use that as the opportunity for telling our story in terms of what some of the significant changes that we need are. And certainly we've done that in terms of the city centre piece around things like the CDC, and there's more to go at in terms of that. Thanks, Sarah.
I think it's Juliet next, unless
Juliet.
This is less a question for you, Stuart. It's, I suppose, more for others, but I'm just wondering about the workforce planning implications of the estate changes, which are kind of, since that's the biggest challenge facing the NHS, I suppose, is resourcing. I just wondered how that was dovetailing into the estates work.
Absolutely. So we've got a piece of work going on simultaneously to develop an integrated workforce plan. So we've got the sort of forecast based on each of our service lines and care groups going forward. And then we're layering on some of the sort of big transformations that we've got, plus the incremental step changes. So that's got us a plan in terms of what we need. Clearly, the work that then needs to happen is around checking that is realistic based on what the forecasts are in terms of the the skills that we will be creating as a country over the next 5 to 10 years. So where are the gaps in terms of skills, and what do we need to do in terms of potentially changing the way in which we're delivering services to reflect the skills that we will have available. So that will be an iterative process, but we've got active work going on to develop that first cut of the wider plan.
Thank you.
Sarah.
Hi, Stuart. Yes, really enjoyed that. Very impressed, I have to say. I'm from North Devon, for those who don't know, part of the Royal Devon University Healthcare Trust. I was just interested in particularly your UTC, just because I sense from your figures you put up, you're going to have some of the same problem we've got, which is we could almost outgrow our emergency department as soon as we've expanded it. So we've made the case with the ICB for a co-located UTC, but it feels like it's quite slow going to get to a sort of model. I wonder what your timescales were for bringing that on stream.
So we've got a bid in currently, which we're expecting to hear about over the next few weeks. If that's successful, then we would be aiming to, and this is a sort of best endeavours basis, aiming to get that building built by the end of this calendar year, operational at the start of next year. We've already got planning in for that building. We've done it. We've taken the tact on that area of designing buildings that are essentially like Lego blocks, so you can build both horizontally and vertically in blocks. So the first stage will be the fracture clinic. The second stage will be the urgent treatment centre. We've got room to expand then adjacent, and room to expand above the fracture clinic. So it'll be a building that looks a bit odd from day one, but gives us the ability to right size it in the long term. So you've got the right mass on that site with the right services being relocated. So if you look at where we are currently, there's something like 70 patients a day that we could probably route out of the emergency department into that facility. And our aim is to try and essentially take all mine up there.
Yeah.
And that should buy us the time in terms of the current emergency department to see us through, next winter and the winter after, until the main facility opens. So really critical part. I guess it's not lost on us. As soon as we build a lovely, nice, shiny building, people will come, and there will be a whole load of demand that actually doesn't currently exist that will turn up at the front door. So again, the urgent treatment centre and some of the other things that we need in place as a sort of wider system are really important to making sure that doesn't happen. Otherwise, you're right, we'll build a building that's twice the size, and we'll end up swamped because of demand that's not currently there. So yeah, UTC is an important component of that.
Yeah.
Brilliant, thank you. Any other questions? If anything does occur to anybody afterwards, do please feel free to use the chat or drop me an email, and happily pick it up offline. But really good to see everybody.
Stuart, just one question: would it be possible to share the slides if that's okay?
Yeah, Brian, are you okay to?
Yes,
that would be really, really useful. Thank you very much.
That's a really good idea. Actually, that'd be really helpful.
Yeah,
and this has been recorded as well, so I'll attach the video as well, so you can have the conversation discussions towards the end of the presentation.
Thank you very much.
That's brilliant.
Thank you. Thank you.
Thank you very much, everyone.